So Pascale earned her master's of social work degree from UBC, and since then has worked in a variety of settings in the BC Cancer Agency, North Shore Palliative Care Supportive Program, and various other ones as well. But those are the ones that are kind of particularly pertinent to today's talk. And since late 2022, she's worked with the care coordinator as the coordinator in the assisted dying program, really supporting people with their requests for MAID in the Vancouver Coastal Health region. She's also an adjunct professor with the UBC School of Social Work, and her main areas of interest in social work practice are around palliative care, MAID, narrative medicine, and grief counseling. And so with great appreciation, I want to welcome Pascale and her colleague Liz to our group today.
Thank you, Elaine, for the introductions. And I apologize that I don't have a more formal introduction for my lovely colleague, Liz, who a little bit at the last minute, we decided was going to support us today. So Liz, do you want to just for a couple of minutes, couple seconds, tell our lovely attendees who you are and your role?
Yeah, sure. Thanks. Thanks for inviting me first and foremost, and thanks for having me in this session. My name is Liz. I'm the clinical educator working within Vancouver Coastal Health for the assisted dying program. So Pascale and I work closely with each other with providing education and supporting various groups and teams across the Lower Mainland within the Vancouver Coastal Health region.
Thanks, Liz. So I'll start with sharing my screen and hopefully that goes smoothly. So again, a great thank you to Elaine for inviting Liz and I to join today. It's my great pleasure to be here with you. And hopefully in the next, 80 minutes or so, I'll go through some content and material about palliative care. We do want this to be very interactive, so I encourage you to put in the chat when I give you some prompts, information that help us guide our shared learning today. So I hope that's okay. Although Elaine did a land acknowledgement, I just want to do one as well, just in the context of Liz and I. We work for Vancouver Coastal Health, which means we serve a very broad population group, including many First Nations, and you'll see their names there. It's always nice to know sort of geographically where we're situated, and some of you may be joining us from different territories across BC. But in terms of Vancouver Coastal Health, we serve the unceded and traditional territories of the Coast Salish people, including Musqueam, Squamish, and Tsleil-Waututh nations. Elaine's already introduced me, so I won't go on about that a little bit too long here. But yeah, my passion really is palliative care, and I also worked with children who were palliative earlier on in my career for about 10 years, and then ended up in the adult world. So I've seen people at all stages of life facing end of life and serious illnesses. And so I've learned a lot, mostly from what families and patients share with us as healthcare providers, as what's meaningful to them and what matters to them. I'm wondering if you wouldn't mind putting in the chat who you are. I think one of our participants already did, but if you wouldn't mind just letting us know who you are, maybe where you live, and who you're caring for. And I'm not sure, can I see the chat as well when I'm sharing, Liz? Do you know right now my screen only shows?
It's really hard. I have not been able to figure out how I can see a chat. So we'll fill you in, Pascale.
I think actually I can. It covers my screen a little bit, but how about you guys do tell me what you're seeing?
We're seeing you perfectly with
okay.
the screen, and we don't see your chat coming up at all.
Okay. So is anybody taking the time, Liz and Elaine, to write in the chat who they are, where they're from?
So we have Priscilla from Victoria.
Thank you, Priscilla.
And we had Bridget earlier this morning, I believe, from Richmond. Barbara, who is in Vancouver and caring for her husband with FTD semantic dementia. Susan in Comox Valley. Her husband has glioblastoma and has been approved for MAID, and they're in Comox Valley. I can't remember if I said that or not.
So thank you. thank you. And again, up to you to put that information or not, it's totally fine. So today I just wanted to review a few things we'll be going through. So we'll be defining palliative care, addressing the myths and things that we hear about palliative care. And some of those things can be somewhat scary sometimes, the words that we hear. So I'll be trying to dispel some of those myths for you, some facts about palliative care, also the various roles that various healthcare providers offer in the realm of palliative care. Importantly, if you're interested in palliative care for the person you're caring for, how to access it, right? And what a palliative care conversation can look like earlier on in the disease process, but also later on, how those conversations can transform and evolve over time. And then, of course, the floor will be open for your questions. Some of the things we're going to talk about today are very sensitive and can bring up some strong emotions or feelings, maybe some things that we haven't allowed ourselves to feel. So I do encourage you to take care of yourself. Elaine mentioned a cup of tea. That can be a very comforting thing. If you need to take a little break and just step away from the screen for a minute to gather yourself, please do so. If you feel tears or other emotions surface, take care of yourselves. Do what you know that you need to do to collect yourself in those moments. We're all here together supporting each other, but do take care of yourself. So without further ado, let's dive right in. I wanted to ask you, what are the words that come to your mind when you hear the two words palliative care? If you wouldn't mind in the chat, just writing down what are the words that come to mind, whether they're positive words or words that you find perhaps a little more frightening or worrisome. What comes to mind when you hear the words palliative care? Dying, end of life, helping the transition to end of life, easing suffering, gentle care, lovely word from Dave, support, support to family, hospice from Bridget, yeah. Yeah, those are all words that are connected to palliative care. Anything else, Liz, that you saw pop up that I missed?
That's it. You've got it all. Well, there's MAID as well.
Made.
And compassionate easing to end of life.
Beautiful words. Beautiful words. Yeah. So, we hear different things that we sometimes hear in the media or in a brochure or healthcare provider. And sometimes we have an idea of what palliative care means, but sometimes it's a little more vague. And I'm assuming if you came to today's talk is you may have an idea, but you want to gain more information and really understand what those two words mean. So yeah, all of those words you mentioned are all correct. They just look a little bit different depending on the timing in the situation. So as you can see on the screen, I have a definition slide. I actually have two definition slides. And you can see that this definition is offered to you from the BC Centre for Palliative Care. So the BC Centre for Palliative Care is a group of people in various roles in medicine who have come together to really dispel the myths and clarify for people what palliative care is. So they do a lot of advocacy and education. And why should I reinvent the wheel? I'll take the definition from the best people here in BC. And this is a couple of statements that they've made around what palliative care is. And you'll see people have somewhat different definitions, but at the core, it's an approach, okay? So palliative care aims to reduce suffering and improve the quality of life for people living with a serious illness. And in your comments, most of you had a couple of these words already in there. And what's important to know is palliative care can be offered in all kinds of places. We often think about a palliative care unit in a hospital or hospice, but in fact, palliative care can be offered pretty much anywhere where you are if you're living with a serious illness. Certainly a hospital, a hospice, but also if you're in a long-term care, an assisted living facility, or even at home, okay? Oops. And this is the second slide that I'm offering you, defining palliative care, again offered by our BC Centre for Palliative Care. That palliative care focuses on the dignity of the person. And really what happens with a palliative care approach, it's driven by what the patient wants, their values, their wishes, including the family as much as possible. But instead of you being told what you might want to do or think about, in palliative care, you're telling others what I need. This is what I feel I need as I'm living with this serious illness. So what matters to you? And we're going to dive a little bit deeper into that into the presentation. Sometimes, depending at the stage of the illness, the focus is really on comfort care, things like managing pain and other uncomfortable symptoms. And often when we talk about palliative care, we've kind of come to a point where we understand that there's no longer a goal to cure the illness, as in a cure may not be possible. We can still have treatments, but there are treatments to keep us more comfortable. My favorite line in terms of defining palliative care is this one, and it's the last one I'll offer you at the bottom. Living well now while preparing for change. Because we know change is coming. We know based on our illness that things will evolve and change, but we're focusing on the present and living as best we can now while preparing for the changes ahead.
I love that.
You like that, Elaine?
I do.
I know, it's a pretty awesome line. So there is a great video offered by Health Canada. So I'm going to stop sharing my screen, and Liz, my technological wizard today, will be showing us this video. If it's at all glitchy or you can't hear it's breaking up, do comment in the chat. We tested it. It was working half an hour ago, but as we all know with technology, it could not. So I'm going to stop sharing.
Caring for someone you love, it's not a burden on you. It brings you joy as well to, be able to support somebody. My grandma's very strong-willed, so she tried her best to be able to do everything independently. It was just that over the years after she moved here, she had gotten older, and also in some areas she became weaker and she couldn't move around as much. Things that she used to be able to do for herself alone became things that she needed help with. Because I have such a close relationship with my grandmother, my career goals were sort of oriented in that way. At work, we deal with a lot of things regarding older adults and chronic disease and management for their chronic diseases. And at home, we've been through a lot of those same things with her comorbidities, with her chronic disease. She has atrial fibrillation, she has hypertension, so she'll get tired more easily, out of breath, those kinds of things. There are risks of heart failure. She also has arthritis and the 2 shoulder injuries. All of these things make each other complicated. My grandmother also suffered a stroke. It impacted a lot of her mobility. She needed a wheelchair to move around. She obviously had a lot more medications afterwards. It's hard for one person to essentially take care of all of these responsibilities. Things like picking up prescriptions, making appointments. There was physiotherapists, visits from the speech language pathologist. We got PSW support. The discharge specialist after the hospital directed us to a lot of these supports, but our role was essentially figuring out what kind of care she needed. When I learned the term early palliative care, I was able to separate it sort of from the definition that I had before, which was just end of life. I learned that it includes care for people like my grandmother who have multiple illnesses that are ongoing and that are long-lasting. That sort of connected those dots for me, that it was not necessarily just about caring for a person at the end of their life, but improving their health and their quality of life. In the beginning, when she came back from the hospital, I would try to do as much as I could so that she would have to do as little as possible. I learned to reel it back a little. It made my grandma happier or more lively when she was able to be more independent. I know that that was really important for her. I'm really grateful to have my friends in my life. I'm able to be vulnerable with them. I'm able to be open with them. And that's, in general, just a really great stress reliever and like a source of joy. I think family is honestly like the core, biggest support system. They're able to be there for me whenever I need it. When you're able to bounce responsibilities off of each other, nobody has to necessarily be overwhelmed with anything. It works much better as a team. When you have that love around you, it makes everything a lot brighter.
Yes. So as you can see on the last screenshot they gave us with that video, they called it again a palliative care approach. So really, when we speak about palliative care, it's our approach. It's not a finite box of things. It's a lot of different things, a palliative care approach. That was just a snippet into what palliative care is. I want to take a moment to read each of these 6 statements, and I'll read them quite slowly. The reason why is I want you to think, is this a statement that you may believe yourself or have heard of? Because here we're going to try to dispel these myths about what some of us may believe palliative care is. So let me read them. Palliative care is only for the last days and weeks of life. Starting palliative care means the person is dying. Starting palliative care means giving up. Treatment stops when palliative care starts. Palliative care hastens death. Palliative care delays death. So in the chat, you may want to number them or not. Have you heard of these myths? So you could say, yes, I've heard of number 1 or 2 or 4 or 5 or all of them or none of them. As you're comfortable, if you wouldn't mind letting us know if you've heard of these myths, and then I'll take a moment to hopefully convince you that these 6 statements are in fact incorrect. Had anybody heard of any of these before, or maybe believed them or read about one of these? One and 2 so far. And then maybe Liz, you can help me. The old ways, yes.
All of them. Number 4 has come up twice as well. Number 5.
Somebody wrote all of them, I think, right?
Yes, yeah.
Yeah.
And then one of the attendees says, my doctor said the number 1. And then 1 and 2 also comes up again.
Yeah, thank you for sharing, everyone. Certainly, somebody also wrote in the older days, right? So when palliative care came into the picture in medicine, it's a relatively newer area of medicine when we think about the trajectory of specialties in medicine. Palliative care is a bit of a new one to the game. And certainly at the beginning, we associated it with the last days and weeks of life. So let me just go through a few of these. Starting with number 1. So in fact, palliative care is not only for the last days and weeks of life. And what you'll learn in the next video I'm going to show you is, in fact, the earlier we start a palliative care approach, the better the outcomes for patients and families. What we've learned is if we address the fact that this illness will slowly erode quality of life and function, the sooner we can support a family and intervene. In fact, people live longer and do better when we start palliative care earlier. And I know that sounds a bit counterintuitive, but that's how it works. And in the next video, you'll learn a little bit about that. Starting palliative care means the person is dying. No, starting palliative care means we recognize that this illness will lead eventually to the person dying. But it doesn't mean the person is dying right then and there. In fact, they're living as well as they can right now. I hear this one a lot as a hospice social worker and a palliative care social worker, that starting palliative care means giving up. In fact, palliative care is opening that conversation to saying, what matters to you? What is quality of life to you? What can we do to make you live your best life right now, knowing that change is a-coming? So it doesn't mean giving up, which is linked to number 4. You can still actively be engaged in all kinds of treatments while still being a palliative care patient. You can have palliative chemotherapy, palliative radiation therapy. You can have medications that make you feel better. That's a form of treatment. It doesn't mean that we think this treatment will, quote unquote, cure you, but it'll make you live better. So in fact, we can have all sorts of treatments, even surgery, while we're still considered palliative. So there's no stopping of treatment when palliative care starts. There, in fact, can work synergistically together for the best outcome possible for the time we have. Palliative care doesn't necessarily hasten death. In fact, you'll find out in our next video, people actually live longer with good palliative care that started earlier. And they don't live longer poorly, they actually live longer better. And it also doesn't delay death because we know at some point the body does what it's going to do. So the time aspect of palliative care is not important as the quality of time that we have. I hope that made a little bit of sense. And if you hear things around your communities or even someone mentioning their physician saying something, you can go, hey, I learned something a little bit different the other day about palliative care. And so the more educated we get, the more we're able to advocate for our loved one and ourselves as well. So who is palliative care best suited for? Well, it's people living with diseases and illnesses which are considered serious, life-threatening, and life-limiting. And I hope those 3 words make sense to you. Life-threatening meaning that if an event was going to happen, that might lead to the person passing away. Life-limiting, knowing that there's a finite of time that someone can live with this illness. And some examples of a serious illness, and many of you mentioned that the person you're caring for are living with these illnesses: cancer, dementia, Alzheimer's, Parkinson's, Huntington's, ALS, end-stage kidney and lung diseases. Certain heart diseases are considered serious, life-limiting, and life-threatening, as are some strokes. Okay? So a couple of facts about palliative care, again, from the BC Centre for Palliative Care, that palliative care pays close attention to some things that may be overlooked sometimes. Things that have to do with managing pain, nausea, difficulty breathing, loss of appetite, and confusion. And I'm asking the question, if you're okay sharing, does your loved one already need help with these kinds of problems? And maybe you want to say just the kinds of things that have helped in the chat. If you could say, yes, my loved one, we're already working on pain, or nausea is the big issue in our family, or confusion. What kinds of problems do you feel you guys are already having to deal with in your lives? People are comfortable sharing. Confusion, managing pain. I'll let Liz comment on anybody else who's saying things.
Confusion has come up again. Confusion, depression, pain, vomiting, breathing, mucus is another one that's been added to the chat there.
Thank you for sharing, everyone. I want to comment as well on depression, right? The mental health pieces that come for people living with serious illness, the physical and the mental health, the psychological. Managing pain, loss of appetite, yeah. So these resonate with you as attendees in terms of what your loved one is already struggling with. Does anyone want to offer the kinds of things that may have helped with some of these symptoms? Anybody want to say anything that may have helped? Whether it's medication, or physical therapy or occupational therapy? Any other things that you can think of that have helped a little bit? We know that not everything can address everything, but anything that may have helped improve some of these symptoms for the person you're caring for? I'll give you a moment. Yeah. What are we seeing, Liz?
There's medication, equipment, home care. There's gratitude meditation, nutrition consultation, and counseling. Someone said something really touching, touch, physical touch, medication for pain and depression, encouraging movement.
Beautiful.
Brain
Brain
wellness.
wellness. A nice homage to Elaine's team and their work. Beautiful. Deep breathing, healing touch. What I love about these comments, dear attendees, it's a combination of more traditional things that we think of, like equipment, medication, but also things that are related to that connection, right? Healing and touch, breathing, meditation. Those are things that have been shown to really, really help the people we love that we're caring for. So thank you so much for sharing that. Sort of in line with that other slide again, palliative care addresses the needs of patients and families, whether they're physical, and we just described that, right? Sort of mobility and functioning, emotional. So tapping into those touch and meditation and those kinds of things. Social, the brain wellness program, coming together with other people so you don't feel so alone and isolated. Practical things like equipment, right? Things that make life easier for your loved one at home. And spiritual. So we talked a little bit about meditation, and there could be other spiritual, religious, cultural needs that you also feel are important as you journey with your loved one. So palliative care really looks at the whole picture. Who is the person needing support? And how can we center that care around all these different needs? And I think we've already talked about some of the needs. So I'll just move on to the next slide to give us plenty of time for questions. So when should we access palliative care? Well, as I mentioned, it really can help at any stage of a life-threatening illness. Again, the earlier, the better, but it's really a matter of readiness. So sometimes I've worked with patients who the word palliative care terrifies them, even if I've explained it to them in a gentle, caring way, they're just not ready. So it's really a matter of when is the person ready and can we access the care we need? And again, it can be offered with all those other treatments we talked about. Yes, and that's where I remember we're at our video. This is an excellent 3.5-minute video from Pallium Canada, where they explain why starting palliative care earlier is better, trying again to dispel that myth that palliative care is only for the end of life. And so I'm going to ask Liz to help me and show this next video.
What comes to your mind when you hear or see the word palliative? Many people, appropriately, think of words such as compassion, dignity, or quality of life. However, for many people, what comes immediately to mind are the words dying, terminal, and end of life. Unfortunately, too few people think of palliative care alongside treatments to control the disease.
I'm Dr. Gordon Giddings. I'm a palliative physician at the University of Ottawa and clinical content editor of Pallium Canada. The aim of this Pallium Doodle is to explain that palliative care is not something for just the last days or weeks of life, but should be initiated much earlier.
To better understand this, let's look at the illness trajectory, starting at the time of diagnosis of a life-threatening illness. In some cases, the disease, whether it be cancer or another non-cancer disease, can be cured with treatments. In other cases, however, the disease may be incurable. Let's draw a graph around this journey. On the x-axis is the length of that journey from diagnosis to death. On the y-axis is the goals of care, the treatment and care options in focus. Now, unfortunately, because people often think of palliative care only for the last days or weeks of life, They will only activate a palliative care approach in the last days or weeks of life. Let's look at the negative consequences of this. They include lack of symptom control with unnecessary suffering, inappropriate treatment choices, prolonged psychological distress because no one is addressing the fears and concerns of the patient, lack of discussions about prognosis, or lack of preparation regarding care choices and treatment goals. So what do we need to do? Well, we need to erase the old model of palliative care and use a different model, a different approach. What if we start palliating early in the illness? This does not mean that treatments to control or cure the disease and palliation and supportive care are mutually exclusive. The model of early palliative care is much more patient-centered and responsive to patient needs. Is there evidence to show that early palliative care is better than late palliative care? In a large US-based study by Timmel and colleagues, the model of early palliative care was compared to the usual or common model of palliative care, only in the late phase of disease. What do you think the results were? Which group do you think did better? Which group had less depression and less anxiety? Which group had better quality of life and symptom control throughout their illness? Which group do you think lived longer? The early palliative care group experienced significantly less depression and anxiety, better quality of life, better symptom control, and astoundingly, they lived almost 3 months longer than those patients who received only late palliative care. So the key message is palliative care early is better than palliative care late.
Thank you, Liz. Can you see my screen again, everyone?
Yes, we can.
Fantastic. The technology is working. What a concept.
Oh.
So moving on, you may be curious to think, okay, palliative care sounds good. Sounds like sooner is better. But who offers palliative care? Well, look at all the squares I've put on your screen. There are many, many people that can be involved in a palliative care approach. And some of you have mentioned already home care and meeting with physicians or nurse practitioners. So let's just go through this list briefly. So for sure, physicians and nurse practitioners are usually the key point person in a palliative care approach. And that can be your family doctor. Most family doctors can certainly start the process of initiating palliative care, or nurse practitioners if they're your primary healthcare provider. You may not need to see a palliative care physician or a palliative care specialist, because as I just said a minute ago, some family doctors are able to start that process with people whose case is more quote unquote straightforward. It really depends, and it'll evolve over time. Certainly nurses, LPNs, and care aides are involved in palliative care, especially for those of us staying at home and being cared for in our homes. We will need that care and support eventually as things progress. We can also be cared for by home care workers, a little bit of different role than care aides, but similar. Social workers like myself and Elaine will work with people who are facing life-threatening, life-limiting diseases to provide counseling support and psychological support. Physiotherapists are often very involved, maybe in the hospital setting and then in community back at home, to help people optimize how their body is moving and functioning as the disease takes hold and progresses. Occupational therapists, if you've never encountered an occupational therapist, you don't know what they do, they're wonderful at helping people interact with their environment. If I can no longer use my left side because of a stroke, how can I learn to use my right side? How can I function with my environment at home to be as independent as I want to be? Speech and language pathologists can be very helpful with those kinds of diseases where we know how we talk and speak and communicate is affected by our illness, and they can come up with communication devices and tips and strategies on how to optimize our communication when that is slowly being eroded as well. Dietitians can be very helpful when we know that certain foods, textures, consistencies, and choices of food may be better for us to live as long and as well as possible compared to other choices. They may help us with food choices, texture, quantity, quality of foods, etc. I'm wondering if already some of you in the chat could tell us, have you interacted with any of these groups of healthcare providers in terms of your loved one's trajectory so far? Maybe some of you have only interacted with a few and others have interacted with quite a few more. If you wouldn't mind just putting in the chat. Any comments so far, Liz?
No, not just yet. Oh yeah, there's a couple now. Occupational therapist and speech pathologist. Yes, doctor, nurse, dietitian, SLP, occupational therapist, physio, nurse practitioner, home care workers, physicians, social workers, OTs.
Wonderful. For those of you who've had and counselors, yes, I see physician. Yeah. So for those of you who've had lots of people involved, that's usually a good thing, as long as the message is consistent and you're not too overwhelmed. It's generally good because everyone will have sort of different strategies and approaches based on their specialty to help you and your loved one out. And perhaps today, for those of you who haven't heard of these different subspecialties or healthcare providers, you may ask for that. It might be helpful. So yeah, thank you for sharing, everyone. We're seeing sort of, Liz, I think a similar group of home care being referred to PT, right? So for Jose there, sometimes we start with a group of people helping us, and then those people say, you know what, I also think my colleague so-and-so could really help you. I'm not as knowledgeable in that area. Let me call my social work colleague, my OT colleague, my PT colleague. As things evolve, you may need different people involved. So wonderful. Thank you for sharing, everyone. That's great. I'm glad it's familiar to most of you. That's reassuring. So sort of the million-dollar question, how do you access palliative care? I think a lot of you are already engaged in some form of palliative care. You may just not know that it was actually palliative care, really depending on the communication with your team. But starting with your family doctor or nurse practitioner is often a good start. People have already mentioned having services offered in the home by various healthcare providers, so home care services. And I'll tell you, if you don't have home care yet and you feel you're getting close to a point where you need help at home, I will show you how to initiate that process. And somebody already mentioned equipment and supplies. So depending on the stage of the disease trajectory, you may be eligible for coverage of palliative care medications, supplies, and equipment. And I can tell you more about that, especially in our Q&A at the end if you have specific questions. I can point you hopefully in the general right direction. So this is what the government tells you. I copied and pasted this straight from the Ministry of Health. Why not? Let's see what our government of British Columbia tells us. So this is straight from their website, and our volunteer can put that lovely link in your little cheat sheet that everyone will get at the end. So what they're telling you is that home care services, if you're interested in receiving palliative care services at home, or you know someone who is, you contact your home and community care office of your health authority. I'll be showing you how to do that if you don't know yet. Or your doctor can make a referral to your home health team in the region and health authority where you live. The thing is, when you think you need something, somebody has to agree. So there is an assessment process where someone will come to your home and see if, in fact, your situation meets the criteria for care. We all know that the need far exceeds the resources, so there are pretty stringent eligibility criteria. But it's all, I always say, if you don't ask, you don't know. So you ask and you see if your loved one may meet the criteria. And if you don't yet, they'll tell you why, but when you should call again and be reassessed. It can be difficult to ask for help when we don't know if someone will be willing to offer it. But again, I encourage you just to ask for the help. You may be surprised that there are other things they can offer in the interim. So some people came from different area. I think we have some people from Comox. Can you tell me which health authority you believe you belong to? Fraser Health is sort of your Surrey, Port Moody, Coquitlam, all the way to Hope. Vancouver Coastal Health is Richmond, Sunshine Coast, North Van, West Van, Whistler, Pemberton. Island Health is obviously on our lovely island. Interior Health is Central BC, and Northern Health is our Northern BC. Does everyone know which health authority they're part of? Does someone not know? So yeah, we have VIHA, which stands for the Island Health Authority, VCH, Coastal Health. Anybody from Interior or Fraser or Northern Health? You do get people, Elaine, right, from all over the health authorities at times?
Yes, we do.
Yeah.
Yeah, absolutely. It's the BC Brain Wellness Program. So we're covering the whole
You
province.
serve everyone. Yeah. Yeah. So what I've done, and this can be added to your resource list, is how to access palliative care within your own health authorities. So that's sort of the link I've given you is the entry link, and then you can keep clicking away depending on your situation. There will be a phone number where if you're interested in receiving support at home, this is mostly targeted for home care services in the realm of palliative care. If you don't know where to start, there are people who answer the phone and will ask you some questions and clarify with you if they should actually come to the home and do an assessment, or if by the sounds of it, you and your loved one are not quite there in terms of meeting the criteria. But their job is to assess and see if you meet criteria to receive palliative care at home. And again, I said that can look like humans helping you in the home, but also equipment and coverage of medication. And during the chat, we can talk much more about access. I want to talk about something that's very dear to me, and that's conversations. Why? Well, I'm a social worker. I can't write prescriptions. I can't help you with the physical PT, OT needs. But what I'm passionate about is conversations that help people and their families to situate themselves when they're facing life limiting conditions. So palliative care conversations should be really happening all the time. They should be evolving as the disease and illness progress, because what was working 3 months ago may no longer be working now. The wishes that your loved one had 6 months ago may no longer be the wishes they have now. Palliative care conversations are dynamic and they evolve with time and with what's happening. But at the center of the conversation is the person living with the illness. So with a palliative care approach, you're having multiple conversations, ideally with your loved ones present, to say, this is how I'm feeling today. This is a goal I have for the next 2 to 3 months. And then we revisit that goal continually. It's also about grieving what we may have lost with this illness, but also dreams of things that we still hold dear to us. And these conversations are very, very important. Some things that are important in a palliative care conversation, and I think when we talked about the olden days, we didn't really give patients enough information about where things were headed. What are the changes you will notice in your own body? What are the changes you will notice with your brain? We felt that it was better to protect people and not give them that information because we thought it was quote unquote scary. What we've learned, in fact, is not knowing is much scarier than knowing. So in palliative care conversations, depending how ready you are, you may want to really know, quote unquote, everything. What's going to happen to me? Will I lose my memory first, or will I lose my ability to eat first? How confused will I be? When will I stop recognizing my loved ones? Will I be bedbound in the last months of my life? Will I need a feeding tube? Should I have a feeding tube? How will I communicate my wishes if I can't talk anymore? You have the right to know where your disease is headed if you're ready to hear that information. In palliative care conversation, we may explore who the supports are in your life. That's very important. How you're coping with this information. How you're adjusting the patient themselves and their loved ones to the changes that are already happening. What I love to talk about is, in the hard times you've had in your life so far, what do you draw on that brings you strength? Everyone has weathered storms in their life. What did the other storms look like, and what brought a bit of peace or solace in those difficult times? The longer we're on this planet, the more we have experiences that we can draw on that we know true to be, to work for us. What are your vulnerabilities? What are your beliefs, your wishes, your hopes, your worries? These kinds of conversations really explore all these things for the person living with the illness, but also those who love them, support, and care for them. As we've talked about, we'll explore cultural and spiritual dimensions in these conversations, and we'll ask very direct questions. I've asked people, what are your goals? I want to make it to summer to see my first grandbaby. That matters a lot to me. What is quality of life to you? People have answered, to still be able to eat. I don't want a feeding tube when it comes to the time that I can't eat on my own anymore. And other things like that. And these conversations that I said do evolve over time. And they can happen with your physician, your nurse practitioner, your home care support team, your case manager, your social worker, with anyone really who's involved in your care and who's comfortable answering those questions and exploring that with you. And as I mentioned, these conversations often happen with the patient and their support circle around them. And over time, the support circle becomes smaller and tighter around that person when the person living with the illness can express less and less what matters to them, and others have to speak for them at times. In palliative care conversations, you also educate the patient and family on what palliative care is and is not, to really have realistic expectations around what is possible and what might not be possible. Some people really want to know the dying process itself, what to expect. Again, not knowing can be scarier than knowing. People want to know, how will I die? Will it be scary for those who love me? What will happen to me? Some people say, I want to be cared for as long as possible at home, but I don't want to die at home. Then we can talk about hospice versus home. We can talk about not wanting to be resuscitated if you're going to have a big event. These are very open, transparent conversations around the realities of end of life. And I think Elaine's already done a talk a few months ago I saw on your beautiful website around advanced care planning. Very important topic. If I can no longer speak for myself, who will, when, and why? So I won't delve into that, but that's all part of palliative care conversations. They're conversations that are sensitive, nuanced, and where you and your family should be talking way more than the healthcare provider. A bit of a flip in how usually healthcare is delivered. So again, who do these conversations take place with? Really, anybody on your care team can have these conversations. They may look a little different depending on the person's specialty. Can anyone write in the chat based on how I described those conversations? Has anyone had with their loved one and a healthcare provider a conversation which they think resembles what I've described, a palliative care conversation? Maybe not exactly, but the flavor of that. Has anyone had one of these conversations? Maid physicians, Susan? Yeah. Talk a lot about quality of life and what may be important in a maid conversation. Anybody else? Case manager, the GP, family doctor, the specialist that's caring for your loved one. Anybody else had conversations that have that flavor?
There's a few answers in the chat. Someone says a few days ago, trachea tube limitations. Yes, with representation agreement. Someone else said made as he is on his 4th waiver.
Yeah. Something's telling me that with his doctor, nurse is visiting now. Okay, good. Thank you, Sharon. Sounds to me that some of our attendees and their loved ones, Elaine and Liz, could use more palliative care conversations. Sounds like we've got room for more of these types of conversations.
I
Yeah.
totally agree. I was just, writing down a few notes, for when we get into the discussion. But one of the first things that came to my mind is that these often feel like these taboo topics that, some healthcare professionals just don't have comfort with, right? And so while they might be in a very ripe position to initiate these conversations, it's either out of their skills, comfort zone, I think, out of their comfort zone. And I wouldn't say out of their skill set, but just out of their comfort zone. And as a result, sometimes they're not brought up when they otherwise should be. Is that your experience, Pascale?
Absolutely. Again, people are scared to go there, but what we've learned from research is patient and families are craving these conversations.
Yeah,
And
exactly.
how do we bridge that gap? Yeah, and in fact, I'm a serious illness conversation facilitator, and I train faculty of medicine, newer docs, how to have these conversations, which seems weird because in social work, it's much more intuitive to have these difficult conversations. I want to make sure I don't miss a comment from Dave. Needed to change name. My husband has vascular cognitive decline, getting stroke, present care facility, but want to bring him home. Yeah. Thank you for sharing. Helps initiate these kinds of conversations. Well, like we said, generally it's the physician, the consultants, the specialists, but it can be, as Elaine answered, any skilled professional, including pastoral spiritual care. Thank you, Elaine, for answering that. Just move on. We just have a few more slides so we can really get to questions. I want you to share, if you're comfortable again, what kinds of goals has your loved one expressed to you or their care team while living with their serious illness? And these don't have to be big goals, just putting yourself in your loved one's shoes for just a sec. What kinds of goals, or have they had an opportunity to express a goal, something that matters to them? It doesn't have to be anything fancy. He wants to go home so we can be together. Isn't that a great goal? To stay at home in a prayerful and happy environment. What a beautiful goal. See how these goals are not medical at all? Anybody else willing to share? I love those two so far, huh? Liz and Elaine, those are pretty precious goals. Very precious.
Really, yeah.
Visit Bowen for his birthday. I hope he does, Jose. Stay as active and normal as possible, as long as possible. Yeah. Did you guys notice there's no talk of medications or treatments or any of those words? We're talking about quality things. Milestones, birthday, staying active and normal, going home, being together in a prayerful environment. Very beautiful. And these are things that palliative care team members can help you with. They can actually help you with. For example, if I'm just going to use the example of visiting Bowen for your birthday, maybe it's having just the right medications for that day so pain and symptom is controlled, or having access to a wheelchair. Of course, I don't know the situation, but it's how can we get to that goal if it's safe and comfortable? What kinds of things can we problem solve to get to these goals? Let me ask you the next one. Worries. If you're comfortable, can you share what kind of worries you think your loved one has? Because a palliative care approach can also help with worries.
I'll just add one more of the goal.
Yes.
Celebration that was shared by Shirin. Today is our 61st wedding anniversary, celebrated with our friends yesterday at the church. How beautiful that is. Yeah.
A wonderful goal to get there, right? To celebrate together at church, whatever it takes. If it's reasonable, let's try to make it happen. And again, I'm inviting you, if you're able, do you think what kind of worries you think your loved ones has? Because I want to demonstrate that a palliative care approach can help with worries as well. We can problem solve. Sometimes it may not be possible, but just having the conversation can really matter. I think he is scared about what's happening to him, worries if he is dying. So for Barbara, right, for your loved one, it's someone's saying, no, you're not dying right now. This is when we'll know, or what dying looks like, and understanding why he may be feeling that way. What is in his body and his mind that's making he think he may be dying, right? It's giving that education, that support, that compassionate care. Anybody else? Not eat, not talk with the tube. That's a big fear, right? Things that make us very human, eating, talking, to be put in a place no one would care, no music, no prayers. I'll let Liz say more.
Yeah, being able to be on the computer to play chess. And then an additional one here, worried that at any given point in time, he could cross over to inability to communicate or express himself. That's a very valid worry.
And again, in a palliative care approach, we could address some of these worries with education and support, and giving you the signs or heads up as to when we know there could be a change. So remember what I'd said, living well now while preparing for change. All of these worries are very valid for your loved ones living with serious illness. And so you, as the person caring, you're holding these worries and fear on behalf of the person you love. That's a very heavy burden to carry. How can someone else help with that? By having those honest, transparent conversations with you and your loved one to say, this is what we'll be looking out for. You're right, this is likely to happen, but we will know. Damn illness taking me away too soon. Yeah. So there are ways with a palliative care approach that we can help with those worries. It doesn't mean erasing the worries. It means supporting them with conversations and giving you the tools and education and perhaps coping skills to live with the uncertainties and worries. And I'm sure Elaine's had a lot of conversations like that as a social worker as well. How do we live with uncertainty? How do we live with worry? How do we carry that in a way that's more gentle and less frightening every day?
Oh my gosh, we are so on the same page, because I just wrote down, living, it's not going to take away the worries or the sorrows, but it's like living, incorporating joy, or not incorporating, but also recognizing the joy that's living alongside the sorrows. So even Shirin, who talks about, having celebrated their 61st anniversary, and that was a big event. But I guess what I picked up on that, what made me think about this, was that comment, and how within every day we have to be open to seeing the joys that are going on alongside our sorrows.
Absolutely. And we were
And
on
there's
the
an
same. Yeah, go ahead, Liz.
Oh, sorry, there's just an additional comment here. He is losing insight that he has dementia, says I will know, but it is not my choice for MAID.
Yeah, Bridget, that's a very difficult situation. When someone's dementia is progressing, and we don't know exactly when that point is where the person is no longer able to communicate their wishes and there's MAID in the background. Yeah, it can be difficult to navigate. And I have a last slide where, again, I'm asking you to give us so much in this chat, and you guys are being incredibly generous. So thank you. That's the only way to keep this conversation interactive. My last question, if you're able to share a little bit more, what do you believe is quality of life for your loved one living with a diagnosis? And quality of life right here, right now, because we know there's been a change. This is why you're here with us today, right? What do you believe quality of life is for your loved one living with a diagnosis? I think Shirin mentioned being together in the church. So being togetherness, a lot of people mentioned togetherness, independence. What do you think quality of life is right now for your loved one? Do you want to read them so I'm not always talking?
Yes, absolutely. Yeah. Yeah, living at home with family around. For us to be together at home with help, but with some privacy for us. An additional one here, love, piece.
And you know what I think is so fantastic about this question that you've posed, Pascale, is that it really speaks to, again, the importance of us having these meaningful yet difficult conversations with the people who are in our hood, you know, the people who are near and dear to us, so that should there come a time that somebody isn't able to articulate what quality of life is for it means to them, that those who are around supporting are then going to be able to put those things in place or respect what they believe their quality of life is. So it's a wonderful question.
And in answer to that question, again, someone mentioned being independent in self-care, capable of being active and working in the garden, able to speak and understand and recognize others or loved ones. Someone else said to be able to cry together, to hug, family celebrations, daily nature, feeling successful in some manner, discovering those activities that help our partners feel normal.
Thank you, everyone. I'm very moved by your comments and your statements. Thank you so much for sharing those. And quality of life is one of those things that evolves even when we don't live with a serious illness. What quality of life meant to any of us at 20 looks very different at 50 and at 60 and at 70. We're all evolving. But when a serious illness enters our world, that becomes even more precious to define and understand. And as Elaine said so rightfully, if we've said it to people while we were still able to communicate, people can keep respecting that for us when we no longer can communicate what quality of life is for us. So that was sort of the end of my more formal presentation. Thank you so much, Liz and Elaine, for helping me with the chat and adding your wonderful, insightful comments. I've allowed you to participate with the chat, but I want to stop sharing right now and really open it up to the floor with questions. And I don't know, Elaine, if you want to monitor that and see how best to manage that. Thank you for hanging in.
I will do that. I just, before we do that, and I take your pin off, I just want to extend a huge thank you to you, Pascale, to for setting such a wonderful foundation and understanding of palliative care and what it can offer people. So with appreciation, before we head into the question and answers,